Welcome to the podcast, Not Your Doc Anymore, where we address the issues essential for your health and provide information to help you become your best advocate. We encourage empowerment through education. I cannot emphasize enough the power of physicians who understand clinical practice and are actually seeing patients on a regular basis and have had years of experience. Here to address the topic of Polycystic Ovarian Syndrome, or PCOS, is a great doctor, Dr. Jennifer Kinghorn. Great to have you.
I'm glad to be here. Thanks for inviting
awesome.
me, Darren. It's a topic I love, and I'm glad you're doing this. I'm glad to be a part of it.
Okay, great. Let me tell you a little bit about Dr. Kinghorn. She's a practicing obstetrician and gynecologist in Salt Lake City, Utah, and has been doing that for the past 25 years. She's board certified as an OBGYN. She received her undergraduate degree at Brigham Young University in biochemistry. She then went on to get a medical degree at the University of Utah. Her internship and second year of residency were at the University of Oklahoma.
It was a great place. People are great. I loved my experience there, but it was good to be back a little closer to the mountains.
She then did her second and third year of residency at the University of Utah, and that's where I really crossed paths most with Dr. Kinghorn early on in both of our careers.
I'm going to just remind you, Darren, I don't know if you remember, but I was actually a medical student under you when you were a resident.
I do remember.
Just a little anecdotal story. The first time I ever really saw an ultrasound, you pulled me into a triage room. And your wife at the time was pregnant with the twin. And you're scanning and trying to teach me about ultrasound. And all I could see was like body parts, and I couldn't. It was my first time seeing a scan with twins. And it was a moment I won't forget.
That's awesome. I wanted to tell a personal story as well. I remember teaching you how to do forceps for the first time. And you were a medical student. I thought you were doing your sub-internship, but I think you were just a medical student at the time. Fourth year.
It was a fourth year.
You were doing your fourth year. That's right. You were doing a sub-internship.
Yeah, I was doing an MFM sub-I.
Yeah, and I remember we went back to the operating room and I taught you how to put the forceps on, how to pull. And I think everybody was mortified with that, with me. But anyway.
I think the attending was Bob Silver, and he was just standing there letting you teach the medical student how to do forceps.
It was so great. It was such
he just
a great
kind of stood there like, eh.
I want to also say that I'm just going to call you Jen. I'm not going to do the formality. But for those who are listening, Dr. Kinghorn, she has practiced in a private practice setting for over 25 years. She was first at Mill Creek Obstetrics, and then the practice at St. Mark's OBGYN Associates in the heart of Salt Lake City. So I also had the amazing opportunity of working closely with Jen in the same practice for very many years. So what a great opportunity, and what a great opportunity for us to sit and talk about medicine again. And that's part of the reason that I'm doing this, is that these interactions have been priceless for me, but I know priceless for listeners who realize these conversations between doctors are so essential for how we can arrive at better treatment plans, better diagnoses, better care for patients. So thanks again.
It's a really important part of practicing, just to have your colleagues. You know, we all are in our exam rooms by ourselves, listening and learning and teaching and treating. And when we put our collective information together, it really enhances patient care.
Isn't it true? That is so true. We are doing this because our goal, and I think you've probably noticed this, that over the past several years, listeners or patients are coming in with information that's out on social media and saying, I've heard this and this is what I would like to do. So we're trying to do what we can to alleviate the burden on clinicians with some potential misinformation that we see on social media, and really provide quality evidence-based information through this same source. So Hopefully today you'll receive information that will be of value to you that you can go back to your provider with. So how about we start with this? Let's maybe talk about the typical presentation of somebody with PCOS. And I know Dr. Kinghorn, for those who are listening, and for me, Jen, and you may call her Jen as well. I know a lot of patients do. Jen, why don't you walk through that? I know there's a lot of things that we need to worry about as it relates to PCOS, but let's maybe talk about the first presentation and how you start your evaluation. And we'll
Sure.
just ask questions as we go through.
Perfect. With polycystic ovarian syndrome, when something's defined as a syndrome, it's because it is a collective grouping of symptoms that we're trying to understand. So not everyone that walks in with potential diagnosis of polycystic ovarian syndrome looks the same. In fact, there are about 3 different diagnostic criteria that would say, hey, you have this syndrome. And you can get 100 women that meet that criteria, but they don't always look the same. So, in terms of what the criteria are, it's not a lengthy list. If you go back to 1990, then NIH had their criteria that kind of started defining this syndrome, and it was irregular periods. So, women that have menstrual cycles that don't fit the 24 to 35 day kind of window, usually because they're not ovulating, some kind of manifestation of excess androgens, testosterone-like symptoms such as acne, hair growth in places that women that are more male pattern, or that they have elevated testosterone levels in their chemistries in their labs. And the third criteria has to do with what the ultrasound looks like of the ovaries. And this is where it gets the name polycystic ovarian syndrome. And I think
Right.
that's a little bit misnomer because I've had patients come in and say, oh, I have polycystic ovarian syndrome because I keep getting ovarian cysts. That definitely is a problem that we like to address and treat, but it's not what is meant by polycystic ovarian syndrome. On ultrasound, the ovaries tend to be larger. They have multiple cystic follicles, usually around the edge of the ovary. And so that's what gives it the classic polycystic ovarian look. Some people would describe it as a string of pearls. So with the NIH, they actually did not, in 1990, they did not have the ultrasound findings as a diagnostic criteria.
Interesting.
In 2003, the Rotterdam criteria came out and it listed 3 things, and you had to have 2 of them. One of them was irregular periods. The second one was some manifestation of excess androgens, either in clinical appearance or labs, and the ultrasound findings. So you could have irregular periods and polycystic ovaries on ultrasound, but not have any manifestation of excess testosterone, and you would fit the criteria. And then the American Excess Androgen Society came up with a criteria in 2008 that included excess androgen, some kind of manifestation, irregular periods, and ovulation, and exclusion of
Dysfunction.
other reasons. Yeah, dysfunctional periods and exclusion of other reasons. So the ultrasound criteria to say someone has polycystic ovarian syndrome because one ultrasound showed that doesn't necessarily meet criteria. Now, when I have patients come into clinic, they're worried about their periods or they have what they think is polycystic ovarian syndrome. We go through that diagnostic criteria and I get a history. So a lot of it can come from history. What are your periods like? What are your periods like off birth control? Because birth control will definitely mask that irregularity. How long have you been irregular? We talk about hair growth, hair loss. They can get hair loss or alopecia on their scalp, acne history. And then there's other things that can confound or exacerbate these symptoms, such as diabetes. We look at body mass index or a history of obesity, or if they're struggling to lose weight, which is something that we see associated. And then we talk about the pros and cons of doing an ultrasound. And a lot of this is all age dependent too, because some teenagers will think, I'm 15, my periods are irregular, I have acne, I must have PCOS. But sometimes in that younger population, those can just be stages of maturation. And as they get older, all of the symptoms settle down.
Let's talk while we're on the period, the menstrual cycle topic, what are we seeing? Maybe let's address that first as somebody matures. What are you seeing with the cycle that is, let's say, normal? And then let's talk about when it goes outside of the norm. And when are we going to be worried about that?
So traditionally, a normal cycle could be anywhere from, and we always talk about cycle intervals as the start of the period to the start of the next period. So not when it finishes, then starts again. It's always from the start to start. And it's really great.
Mm-hmm.
A lot of women are coming in with their period trackers and their apps on their phones, which has revolutionized this for us.
Totally.
Because people used to haul in their kitchen calendars where they would know and they didn't really keep track. And it's hard to see how often they're being irregular. So 21 to about 35 days is considered your normal interval, anywhere from 3 to 5 weeks from start to start. So anything within that window, I don't necessarily get really worried that they're having significant PCOS. Now, when we start getting outside that interval, or we're having like, oh, sometimes it's 4 weeks, sometimes it's 8 weeks, sometimes it's 6 weeks, sometimes I can go 3 months, and there's no predictors to it, that's when I start worrying that they're not ovulating consistently and that there's a hormonal imbalance. The root cause not always known, but we start looking for reasons why the cycles are irregular. Now, when women come in saying, I get a period, and when it comes, it doesn't stop for 3 weeks, that's also a tip off that they're having bleeding that's not necessarily generated from ovulation and that there's a hormonal imbalance somewhere in their system.
I know we're talking about PCOS, but this is maybe a perfect time to address what are some of the other things that we should think about for a woman who has a cycle more frequent than 21 days and greater than the 35 days. And it doesn't have to be a comprehensive list, but when
Yeah.
somebody's coming into your office and they're saying, oh, my periods are every 6 months, what are the things that you typically think? This is obviously not a test, but I think to provide somebody with
It's a really good
answers.
question. It's definitely, I do have a list that I always run through in terms of other endocrinopathies that can affect the menstrual cycle. And when we look at excessive menstruation, meaning it's closer than 21 days, that typically is a much different list. They can overlap, but I'm going to start with the periods that are not consistent, greater than 45 days or more. In my list, I always think, thyroid dysfunction is really quite common. And the menstrual cycle, or the regulation of the menstrual cycle, can be very dependent on thyroid. So that's always one of the first things I look at. I also look at, if they're really far apart, like you said, every 6 months, anything more than 3 months apart, I always wonder what's their prolactin levels? What is their pituitary gland doing? Because some women can develop excessive prolactin that will
Yeah.
interfere with the menstrual cycle. So we look at prolactin levels. You always check a pregnancy test just to make sure that one's off the list. But then I start based on their history. Is there a strong family history of diabetes? Are we struggling with weight loss? Maybe we've got some insulin resistance or prediabetes. So I always look at a hemoglobin A1C to make sure I've evaluated for that. I also look at the hormones that regulate ovulation, the FSH and LH that come from the pituitary gland, because that also can give us a good insight into what's happening there. Is there maybe a premature ovarian failure, or is there
Hmm.
maybe, if they're really underweight or super active and they've got really spaced out periods, they've got a whole different spectrum in terms of regulation that has nothing to do with PCOS.
What do you mean by that,
So there
Jen?
are
Because
some
I think
women,
that's a
and
very common thing that you'll see.
yeah, and we see this in, we would call it hypogonadotropic hypogonadism. But basically, what it means is that either due to exercise activity level or a really low body mass index, it's like the body shuts down in terms of reproduction. It doesn't want to ovulate, it doesn't want to sustain a pregnancy. And it happens at the level of the pituitary, not necessarily the level of the ovary. And I see this sometimes in women who are long distance runners. They've had years of ballet training, gymnasts,
Yeah.
women who really either are so active or they really focus on having a low body mass index. And that's a whole different reason why the cycles can shut down or become very spaced apart quite a bit. And that can be seen in estrogen levels as well as the FSH and LH. So I will look at those based on their history and
That's
see if we
good.
think that's part of the problem. I've had a couple
Yeah.
of patients over the years that have premature ovarian failure, and their ovaries have just stopped working. It's like they hit menopause at 25.
It's
And it's
crazy.
really uncommon, but it can happen. So the FSH is a really good marker for that. So that's always part of my laboratory evaluation.
That's great. Okay, so I know that you touched just briefly on it. So if somebody, which by the way is an amazing review, and it's not by any stretch totally comprehensive, if we are looking at the more frequent than 21 days, what are the things that you're thinking about there? Because that's also a concern.
That can also be a lower body mass index. I tend to see that a little bit more. I would look also for different anatomic things, maybe from the uterus, polyps, fibroids, things like that, that can really make the lining of the uterus unstable. It depends on how long it's been going on and how acute it is. An ultrasound is a wealth of information in regards to that because it lets me see how thick or thin that lining is. And that sometimes can give us a lot of information about where we think this is the excessive menstruation is coming from.
That's great. So when you add the picture of hormone therapy on there, like a birth control pill or a Depo-Provera or a progesterone or an IUD, where do these categories fit as far as somebody worried about menstrual irregularity and PCOS?
But if it's a PCOS type picture, and like I said, usually some clinical or laboratory manifestation of excess androgens, you're still getting periods, but they're maybe 6 to 8 a year, somewhere in there. We want to keep the cycle regular. One of the hallmarks of the PCOS is, like I said, this excess androgen, and the birth control pill, a combined oral contraceptive, does a great job in both regulating the cycle as well as helping decrease the androgen effects. So it can be helpful in slowing down hair growth in places you don't want it.
Wow.
It can be helpful in treating acne because of the way it chemically works in the body to help decrease androgens. In terms of hair loss on the head and alopecia, it does a pretty good job there in trying to slow that process down, but there's other medications that can be helpful. For women
Great.
who maybe are on that spectrum of I'm an ultra marathoner and I'm only getting my periods 6 times a year. The birth control pill I think is helpful in providing contraception, but with PCOS, I worry more about not having a period than I do the women who are not having a period because of other reasons, because that their estrogen levels tend to be higher, which can affect the lining of the uterus. And long term, that puts them at increased risk of precancer and cancer of the uterus. So they definitely need to be on, because the hormone they're missing is progesterone. They don't ovulate, and so they don't make progesterone, and that's what helps keep that lining healthy and regulated. And if they don't have that progesterone in their system, then down the road, those are the things I worry about. So back to your question, what is the best thing? It depends on what we're working with, and it depends on what we're treating and what our goals are. So
Sure.
for example, if I have a PCOS patient coming in, she's in her mid-20s, I can't lose weight, my skin's awful, my periods are all over the place, and I keep bleeding through my clothes. I said, let's get some birth control in your system because it's going to work better than an IUD in terms of helping your acne. Now, the IUD, like a Mirena, that's progesterone, would be great to help your bleeding and protect your uterus lining, but it's not going to help the hormone imbalance as well as a birth control pill would.
That's good.
For excessive bleeding, we definitely want to keep that in check, and a birth control can really regulate that as well.
Gotcha. So we've talked a little bit about the evaluation. Talked about some labs. I think we had talked about an estrogen level and an FSH, potentially an ultrasound. That's not always, do you always obtain that for a patient? It all just depends on their history. When are you typically doing an ultrasound?
Depends on their history and their age. and how helpful I think the ultrasound is going to be. If I'm worried that they maybe have some other kind of, maybe, let's say they're having really excessive menstruation, I want to see if they've got some kind of cyst, or they're having pelvic pain, or they were totally fine and then all of a sudden they're having a lot of irregularity and there's not the chronic history, then yes, I want to see what those ovaries look like on ultrasound. I want to see what that lining looks like. But if they come in with a pretty chronic history and they just have never been able to see anyone to help them with regulation, I talked to them about an ultrasound. I don't think it's going to change what we do in terms of what we offer to help control symptoms. And then we decide together if an ultrasound would be a helpful tool.
That's great. Okay. So then we added a thyroid test. Are there any other tests that you're thinking about doing when you're walking through your evaluation?
Sure. So if I suspect PCOS is our picture, and it's not like the ultra marathoner that I think has maybe a completely suppressed system, I will always check thyroid, hemoglobin A1C to make sure diabetes isn't a big factor. In fact, I did this on a patient. She fit the profile for PCOS, and the hemoglobin A1C came back at 10.
Wow.
Floor diabetes.
Yeah.
And
So
she had been
for the listener,
exercising and dieting, and she'd been doing all the
wow.
things. Ooh, we need to get you with someone else to treat your diabetes, and I think things will fall in line.
That's
I
great.
have
That's
unearthed
amazing.
that a couple of times.
Yeah.
So thyroid,
For the
diabetes,
listener, real quick, what is
yeah.
our range on the hemoglobin A1C ish?
So
What are you looking for?
so if you look at the breakdown for, they do, some labs will give you like a pre-diabetic window or more of the
Okay.
insulin resistant. And usually if we're hitting 5.7, 5.8, up until about 6.5, that's going to be, we've got some kind of difficulty with the body recognizing insulin to regulate blood sugars and things like that. And you may need some help there.
Okay.
And that kind of helps direct treatment. If we're 6.5 and over, we've got a diabetes problem, need aggressive treatment. And for
Yeah.
someone that will
Wow.
just help everything come back in line when we treat the diabetes. So those are the ranges that I look at with the hemoglobin A1C. I used to do fasting insulins and look at fasting insulin to glucose ratios and things like that, but the evidence doesn't support that that's really helpful in terms of targeting your therapies. I think it's
Gotcha.
more of an academic number. And it's such a hassle to get those. You got to come in fasting and you got to do this, you got to do that. The
They're
hemoglobin
hard.
A1C has just become my kind of to give me an idea of where they are in that window. So that's the range. If we're starting in the high fives, low sixes, I'm like, we can
Okay.
have
That's great.
benefit from a insulin sensitizing medication.
That's great. Any other labs?
So if I really want to delve into, so androgens are part of this problem, the excessive androgens. Now, there are some other conditions that will give you excessive androgens outside of PCOS, and you'd have to look at specific ones. For instance, a DHEA sulfate can be a marker for an adrenal tumor that's producing crazy amounts of androgens and
Okay.
usually giving really severe, like, growth patterns, really severe acne. And so if I'm seeing that clinically and I think that number will be helpful, then I'll get it. But it has to be like
Hmm.
700 or higher. A 17 hydroxyprogesterone is going to be a level that will look for non-classic congenital adrenal hyperplasia,
Okay.
so that the adrenal glands are more of the problem. But usually I just look at a free testosterone. Sex hormone binding globulin will help you see where that is. If that's really low and the testosterone's high, then that fits the PCOS picture. I don't always order that, but
Okay.
I for sure order it FSH and LH. And like I said, a prolactin if the picture fits it.
Right.
And then those are my go-to labs.
Awesome.
And if I question on where their estradiol, is this a, because I've had some patients look like the marathon runner in terms of I'm not having periods at all. And their estrogen levels are okay, their FSH and LH are fine. And They just don't ovulate. I've had a couple people fit into that window.
Gotcha.
Progesterone's not a helpful lab because it's a very transient lab. I see a lot of people come with progesterone levels and it's always low. You have to catch the window for it to be
Yeah.
high. So
Right.
it's not part of my routine to do a progesterone.
That's good.
Trying to think
Love it.
what else. I think those are the ones I always like to hit.
Sounds great. Okay, we've talked a little bit about menstrual cycles. It may be helpful to talk about this excessive androgen stuff. But what should those who are taking care of these patients be looking for? Or what should the listener who could potentially have these issues be looking for?
Excessive androgens, it's a tricky one because the manifestations of excess androgens can vary depending on ethnicity, skin color, things like that. For instance, if you take someone of a more Asian descent, they just traditionally don't have a lot of hair. And so you can have someone that has very little kind of that hirsute appearance, meaning that they're getting a little bit of hair on their chin or around their breast or in a male pattern pubic hair. They may not have that, but you check their levels and it's high. It's just because their receptors aren't great. But you can also have someone of a Mediterranean descent who looks like they've got a lot of excess androgen based on their hair growth pattern, but you check their levels and they're fine and they have normal menstrual cycles. So there's an ethnicity piece that you have to pay attention to. The excess androgens manifest as like acne, and it's not just the little pimples here and there. It's like the really cystic, difficult acne to treat. It tends to be a little more resistant to the simple treatments. Hair growth patterns, darker, coarser hair, chin, chest, lower arms, inner thighs, pubic area, and it just is that thick, dark male pattern. Some women even get them
Gotcha.
on their back, above their buttocks area. In some of the literature I read, there's like certain classifications if you want to get into kind of the more academic picture. And those are probably the two
Yeah.
mainstay symptoms we find. There are women
Gotcha.
who start having alopecia, male pattern baldness, the receding hair in their 20s. And you're like, oh
Wow.
my gosh. And it's a manifestation of that excess androgen.
Gotcha. So
Right.
when you said check the levels, I just need to make sure I'll understand what those levels are. And when you're checking those levels, what are you actually ordering?
I'm
Uh,
ordering just a total testosterone. And this has been a great review. Free testosterone. The thing about when you order hormone levels, you're depending on your lab and their technology.
Gotcha.
And so from what I read and what I could see, the free testosterone, it's not as indicative. I was taught like there's the total testosterone and your free testosterone, which is your active testosterone, but it's all very dependent on the technology of the lab. So it's not consistent from lab to lab. So it's hard to say that this certain number, no matter what lab you use, is going to be the number that tells you have it. But generally, if you're over about 50 on total testosterone, you're in that hyperandrogenic world. If you really want to do a free testosterone, you have to get a sex hormone binding globulin because that's how they calculate it. So their labs are just, I think, extra money.
Gotcha.
Yes.
Since we're on that topic, one of our listeners asked any treatment for hair loss caused by PCOS?
So treatments for hair loss specifically, this is a tough one. Once the hair loss starts to happen, it's hard to get it back. And I usually what we want to do is we want to block the androgens so we don't increase that hair loss. And there's two ways to do that. One is birth control pills. And the way that the estrogen and the combined oral contraceptive works is to increase sex hormone binding globulin, which then will block how active the testosterone is. The other mainstay treatment that we use is called spironolactone. And it is an anti-androgenic drug. It can be used for blood pressure. It doesn't really affect the blood pressure that much. I have a lot of women use it and do fine. They don't pass out from it. And that also helps decrease that alopecia effect, usually in 100 to 200 milligrams a day.
Okay.
So those are
So,
two treatments to help get to the root cause of the problem. If we're really struggling, I sometimes will refer them to a dermatologist to see if there's other topicals. Steroids been looked at. Not all of them are going to do great as far as alopecia, but those are the two that I start with when we're struggling in that department.
It's great. So what I'm hearing is that it may be better to get after the hair loss earlier, to use the medications that are going to block it rather than trying to recover the hair loss you've had. Is that, am I hearing that correctly or no?
Yeah.
Okay.
Yeah. Because once that follicle is gone, it's hard to get it back. And the same with hair growth. So if we've got a kind of hirsutism kind of pattern and hair growth, once those follicles have changed, it's hard for them to regress. And it does take a long time to see medication effects on hair growth patterns, whether it's hair loss or hair growth, meaning that you have to be on medications for at least 6 months to see some kind of appreciable difference
Yeah.
because of the way the hair
Okay.
cycle, the hair growth cycle.
Okay. Any other things that we should address in the androgen specific areas? We've talked about presentation. Any other treatment things that we should cover within this department?
Now, one thing that has come up over and over in the literature that we know works with PCOS patients, there's the ones that struggle with being overweight or obese, and that exacerbates their symptoms. And then there's the other category that have a very normal body mass index. And we don't know if they've got two different etiologies because we don't know the exact etiology of this syndrome. But in the
Mm-hmm.
women who struggle with weight loss, we know that when women who are diagnosed with PCOS, if they are able to be aggressive with weight management and lifestyle, losing sometimes 15% of their body weight, that often will help mitigate a lot of their symptoms. The androgen symptoms get better, the cycles get more regular, more ovulatory. Now we've seen this with on the onset of gastric bypass patients. I can clearly remember a couple of patients early on in my career where they were told that they could never get pregnant because they never had regular periods and they were always heavy. They get gastric bypass, they lose a lot of weight, and poof, miracle pregnancy. Because losing the weight and improving their body mass index help their body function better. It's like it helps the hormones balance out. So we know weight
Gotcha.
loss is, and that's hard because I have many patients who are diagnosed with PCOS, they have it, they do everything within their power with diet and exercise, and they lose 3 pounds. And it's not because they're not trying. And I think our society has this mentality that if you can't lose weight, it's your fault. Not true. This is an inborn metabolic issue. And this is where medications like metformin, which is an insulin sensitizer, can be really helpful. There have been women who have lost weight enough that everything settles down. They become ovulatory regular cycles. And there's newer literature coming out about the GLP-1s and how they can help in the polycystic ovarian syndrome patient too, trying
Interesting.
to help reset the hormones because it is also an insulin sensitizer. It helps the body utilize the insulin it produces. It blocks glucagon. It helps with feeling full. It helps your body not crave that hunger noises, the food noise, I guess is what they call it. So it works in all sorts of ways. And there's promising research that it helps PCOS patients.
Great. I know we're covering some of the treatment options and some of the things as we go along, which is great. And then we talked a little bit about an ultrasound. Let's talk, if we can, for a little bit more about the ultrasound findings. Why are we seeing those? What's it called? String of pearls?
And what I could tell from the radiology literature, no one's really agreed 100% on what constitutes a polycystic ovarian syndrome ultrasound finding.
Okay.
They've looked at, okay, so we see all these little cystic structures, they're all about a centimeter or less. And if you have 12 or more, that means you have polycystic ovarian syndrome. It includes a bunch of people that don't have it. They have regular periods. They
Yeah.
don't have any androgen excess. And then they said if their ovaries this size or bigger, when they calculate the volume of the ovary, that means you have PCOS. Not always. So ultrasound's a tool to help us sort things out, but I wouldn't use it as a diagnostic criteria.
Gotcha.
at all. We know that in polycystic, the way they look like in laparoscopy, bigger ovaries, they look almost a little shiny and smooth. The surface or the cortex of the ovary has a different appearance. It almost looks swollen. And if you were to look on ultrasound, you see all of those little follicles. So there's definitely some characteristics, but I wouldn't use it to secure a diagnosis because you can,
Gotcha.
and there are some times in if you take a teenager who's within the first couple of years of menarche, and you do an ultrasound on her ovary, you can see a very classic polycystic looking ovary, but it's just part of her maturation. So that's
Okay.
why, especially in the teenage population, I think ultrasound is less of a helpful tool.
Can you, just for simplicity, tell everybody what ovulation is as it relates to the ovary and a cyst, and just so that we're educated about that process?
Absolutely. Yeah, because if you do an ultrasound on someone who's about to ovulate, you're going to get diagnosed with a cyst. So part of the normal physiology of the ovary, a woman has a period. She's not pregnant. The body says, okay, we're going to shed this lining. And then from the minute that period starts, the ovary's like, we should get ready to try to get pregnant again. So the signals from the brain start stimulating the ovary. And within the ovary are all the eggs that a woman will ever have. They're there when she's born. And what will happen is that the ovary is stimulated with follicle stimulating hormone. One of those little preantral follicles, you can barely see them, starts to mature and it starts to produce estrogen. And eventually, one follicle, typically every month, gets recruited to be the follicle. And it usually gets to about 2 centimeters in size. So, on anyone that's about to ovulate, you'll see a 2 centimeter fluid filled pocket on the ovary, and that's where the egg's ready to go. Now, once it's released and ovulation's happened, that little cystic structure then starts to develop progesterone. And it produces progesterone because that's what gets the lining ready and matured in hopes of having a pregnancy or being implanted in. So anytime a woman's ovulated and you do an ultrasound, like a week later, you'll see a little cystic structure, maybe enhanced a little bit, and that's the corpus luteum, normal physiology.
Gotcha.
And if the egg isn't fertilized, it just goes away. The corpus luteum starts to shrink down. And so, right around the time, and the rise and fall of that progesterone is what brings on the cycle. So, the cycle happens, the body's not pregnant, it starts that process all over again. So, when I like to, if I'm wondering, is this some kind of persistent cyst or polycystic ovarian syndrome, I like women to get ultrasounds around the time of their cycle because that's when the ovaries are the most quiet and we can see what their baseline is to see if there's any pathologic cystic findings.
Gotcha. That's great. I think there's enough questions that occur with that. I just wanted to make sure we clarified that. And so with
Absolutely.
polycystic ovarian syndrome, I'm thinking out loud for everybody. Are there times when, if ovulation doesn't occur, that cyst that doesn't become quite dominant, that ruptures? Can we see cysts that are then small and then we're seeing multiple times that it just never really quite gets to the point that it ruptures and
And
we
it's
get the
matured
corpus
and
luteum
ready
you're
to
talking
go.
about?
Absolutely. That's exactly what happens at the ovary level. At the ovary level, we know in polycystic ovarian syndrome, there is more androgen production. We think about 75% of women's testosterone levels actually come from the ovary and not from another source. The adrenal gland produces about another 25%. But a majority of women's testosterone comes from the ovary. And the thought behind PCOS is that there's so much androgen production there. And that if you look, they've just got the inner part of their ovaries just so big and dominant that it's that imbalance that doesn't allow for a mature follicle to get recruited for ovulation. So it's like the ovary keeps trying and trying, but because of the hormonal imbalance at the level of the ovary, you don't get consistent ovulation. You may get it every once in a while, but That's why you have all of these follicles or these cysts around the ovary. They've tried and they can't mature because there's such a dominance of testosterone or androgens at the ovary level.
Gotcha.
So that's the physiology of what's happening at that point. And that's why you get all these little follicles around the ovary. And they're usually in a pretty classic pattern.
Okay.
Versus someone who has a cyst, which is like one big one, or maybe one big one divided into two. And that's a whole different pathophysiology.
Okay. Good. We've talked about some presentation. We've talked about abnormal periods. We've talked about excess of androgen. We've talked about the ovary being polycystic. Is there any other areas that we should talk about in that area?
So with acne, what I usually do is prescribe a birth control pill and or spironolactone, because again, acne is androgen driven. In my prescribing world and treatment of acne, I say, hey, let's try some oral contraceptives, combined oral contraceptives. And there are certain ones that I will choose versus others if our drive is to get androgens down. The difference in birth controls is not the estrogen piece, it's mostly the progesterone. And there are some progesterones in birth control pills that will actually increase androgenic effects. And there's other ones that are meant to really suppress androgens. So I usually choose birth control pills specific for that. I sometimes will couple them with spironolactone. But I also have them consult with a dermatologist to get the latest and the greatest in terms of topical acne treatment, whether they need to be on Accutane or some other medications. Antibiotics can be useful. I tell them this is what I can do from my side. You may want to visit with a dermatologist to make sure that you're getting a full spectrum treatment of your acne. I consider myself a full spectrum treater of that.
Perfect. Yeah. But that's a big deal for a lot of patients.
Yeah.
So that's awesome. Covered that.
I have actually had, it's interesting, I've had some patients come to me on birth control pills from their dermatologist. I'm like, good on them for doing that.
Yeah.
But most dermatologists don't want to get into the birth control prescribing side of things. So we just work together.
That's great. Okay. I think we've covered some of the treatment things for it. And I want to just make sure we're addressing the questions that some of our listeners had. I know that some asked about diet. Is there something about a low glycemic diet? Is it encouraged anymore? Is it not?
That's
and
a good
how
question.
can we really address some of these symptoms through diet?
So the diet question, I looked into that, and the literature doesn't across the board support that a low glycemic diet is going to be the magic. And what I mean by that is there was a study that looked at low glycemic index. They put them on a little more traditional diet. And even there was one that was like low fat, high carb diet. And the outcomes in terms of weight loss and management of symptoms was not very different. Now, having said that, I think we could all be healthier in our carbohydrate choice. And I think going with more complex, low glycemic index carbohydrates are going to be good for anyone and make anyone feel better. But I don't think that would be the magic bullet.
Gotcha.
I think the big part of this condition is that insulin resistance. So your body's trying to manage the carbohydrates that you're digesting, and what the insulin does is will allow the cells to take up the breakdown of carbohydrates, that glucose that your body needs to function. And insulin resistance is when the cells don't recognize that insulin very well. And it takes a lot of insulin for your body to get that glucose into the system. And so insulin sensitizers like metformin, and like I said, the GLP-1s also do this. That's probably going to be the best if we've got a really insulin resistant type picture. So back to diet, you said, I think because it falls into that kind of insulin resistant picture, I think I always counsel patients making sure you're getting enough protein in your diet, almost eat like a diabetic, because that's what your body's going to function best on. You want to make sure you've got enough protein in your diet, that you're eating complex carbohydrates that won't spike your blood sugar too high, and that you couple your proteins and your carbs.
Okay. I just want to make sure that everybody understands two terms that we use. One is the glycemic index and complex carbohydrates, and I think that may fit in the same category, but maybe just give me
Yeah.
just some details for simplicity
So,
for everybody.
okay. So a complex carbohydrate is a carbohydrate probably in its most natural form. And the more complex the carbohydrate is, it means that it takes your body longer to break it down. For instance, whole wheat bread versus the Hawaiian sweet rolls. The
Right.
more processed your carbs are, the faster your body will break it down, the faster your blood sugar will spike, and it can cause you
Mm.
to swing. And a low glycemic index is just another way to say that, meaning that it will just carbohydrates that take longer to break down. They're not going to spike your blood sugar as fast. So I think those terms,
Gotcha.
as far as I know, I'm not a nutritionist, but as far as I see them, I use them interchangeably. You want to have as little process to your foods as possible.
Gotcha. So can we maybe say that the better it tastes, the higher the glycemic index is?
The faster it is to get, the probably higher the glycemic index. Oh,
That's an
I
awesome.
here's an example. Like I had a patient that now she was diabetic and pregnant, so we're working with the gestational diabetes things, but that has the same pathophysiology. It's insulin resistant.
Yeah. Yeah.
And she was eating oatmeal for breakfast and she couldn't understand why her blood sugars were so high afterwards. But she was eating instant oatmeal.
Yeah.
Has a ton of sugar in it and makes it taste really good and you can cook it really fast. We need to go back to the basic oatmeal and that you put the honey in and you put whatever the sweeteners in yourself. So you're right. The better it tastes, the faster you can eat it, higher the glycemic index.
Oh, I love that.
So,
That's
so
good.
that
It's
so
perfect.
glycemic index, complex carbohydrates, just think of it as the longer it takes for me to prepare and to break it down, probably the better it is for me. But the key also is to making sure you've got your proteins to balance your carbs. Insulin resistance or pre-diabetes, however you want to put it, PCOS, they're always going to feel better and do better on a higher protein type.
Great. That's perfect. I think we've covered the diet. I think that probably addresses the questions.
So
Let's
yeah, a low
see.
glycemic index diet, I think it's great for everyone. In the studies, they've shown that it's going to be one of the tools I think that can be helpful, but it's not going to be the magic. I'll just add in one more lifestyle thing.
Yeah.
Exercise. There was a study that looked at how long people exercised, and it seems like the longer duration of exercise seemed to be most helpful in weight loss and management with PCOS. So going for a long walk, going for a long hike versus a 20-minute pump fest at the gym. Does that make sense?
Yeah. Great.
So that's one of the pieces of information I gleaned.
Okay.
So exercise and diet, definitely helpful.
I don't know if there's a right answer, and I think hopefully we can send this message that there is definitely different presentations that occur with PCOS, but a couple of our listeners asked the question, so I need to ask it. And the question is, and I'll just group them. What are the first symptoms that we should watch for? Are there things that we need to be aware of for parents and patients and
Yeah.
listeners?
So that's a good question. And we typically see the manifestations of PCOS in the late teen, early 20s. And the reason I say that is because those first 2 to 3 years from menarche and out, what can look like PCOS is just normal maturation. And it's like they grow out of it as the whole system gets its balance. So if we see someone that had menarche at 13 and at 17, we've got cystic acne, we've got struggles with weight, we've got periods that have never been regular, then I'm going to think that we've got some kind of hormonal imbalance going on. But that same person, if they're 14 or 15, I would say, let's just treat the symptoms as best we can, but I wouldn't put the label on it to say for
Gotcha.
sure it's PCOS.
That's great.
Signs and symptoms, like I said, it's girls go through tanner development and the staging, how the hair growth comes in terms of pubic hair and other places where secondary hair growth happens. That kind of can be a sign. Menstrual irregularities, I always tell patients, especially if they're asking about their daughters, I say, give it a couple of years. It's not unusual to have kind of irregularities to the cycle the first 2 years that they're having their periods. Now, if you have a teenager that been regular, but then let's say they're a cross country runner or they're training for something and they're really putting a lot of stressors on their body, sometimes that cycle will check out for a month or two. So we have to look at kind of circumstances and environment as well. So that's where we see it starting to pop in. Women who have been diagnosed with PCOS, sometimes as they hit their late 30s, early 40s, will all of a sudden start seeing, hey, my periods are regular now. Hey, my skin isn't so bad. It's like all of their symptoms start to fade away. And one of the theories behind that is that the ovary itself is starting to slow down. And so it's not producing those androgens quite as much as they were before. And I don't know that I guess you could grow out of PCOS. But yeah, we do see that sometimes as well.
That's great. I'm going to address this question that one of our listeners has, and I think, and maybe just add something afterwards, but the listener asked, medication management, no one has a definitive answer for treatment. And I'm gathering from some of this is the reason maybe we don't have a definitive answer is that we don't have a definitive presentation. Maybe you can comment on her question.
Yeah, and that's a good question. And because it is a syndrome and not everyone presents exactly the same way, you have to tailor the treatment to what symptoms are most prominent and bothersome. I would love to cure PCOS in women, but because it's not we can't get down to there's not just one source of the problem. Just that's the way these syndromes work. So I tailor my treatments based on what we're struggling with the most. I tailor the treatment on what the biggest problems are and try to manage the symptoms as best as we can. There are people that will respond better to metformin than others. There are people that we can't use combined oral contraceptives, so we try to find another solution with maybe just cyclical progesterone. So yeah, not everyone looks the same, and so we have to tailor the treatments based on
That's
what
great.
symptoms are the most bothersome.
Do you think we should cover anything more on metformin?
No, I used to use my fasting insulin to determine if I would use metformin on patients. If we sense that there's a huge insulin resistant component to their PCOS manifestation, then I think metformin is very appropriate. But if most of the manifestation is, let's say, excess androgens, they just really struggle with hair growth and acne, but they don't seem to have a really high hemoglobin A1C or something like that, the metformin isn't really going to help with the androgen aspect. It helps with the insulin sensitizing, which in some patients will help correct the androgen excess, but there are patients that fit criteria that the insulin resistant isn't a huge component to their presentation.
Gotcha. Okay, I'm going to just say I'm ignorant on this, but the question is, does Zepbound actually help PCOS? Is that one of the GLP-1s?
Yeah. Zepbound is one of the GLP-1s. And like I said, the information is promising, but I think it's going to be helping the patients that respond best to weight loss or who come into the PCOS syndrome with the more obesity picture. For someone who is normal BMI, super active, has a very healthy outlook, but they just don't ovulate regularly and they struggle with their acne and hair growth, I'm not sure the GLP-1 is going to be as helpful as it would with kind of the other kind of little heavier, hard time losing weight type of PCOS.
Okay,
Again,
so
the information is new on this, and they could be finding it will be helpful, but we're still learning a lot about the GLP. Yeah, we're still learning a lot about the GLP-1s, and we're getting a lot of good information with as widely as they're being used.
Great. Okay, this listener asked this question. I've got PCOS and I have 3 girls. will they get it, and what are the first symptoms to watch for? We already talked about the symptoms, so maybe let's talk about the genetic component of PCOS.
Yeah.
Is there something there?
They haven't been able to nail this down to one particular gene mutation that this is why you have it and this is the genetics of it. We know that kind of these metabolic syndromes, and I'm going to place it in that because there's a lot of things associated with PCOS that have to do with metabolism and have to do with how people carry their weight and the insulin resistance that we see in families. Is there a guarantee that all three daughters will have it? No, you can find plenty of families that like one person pops up and the other ones are fine. But if there is family history, yeah, you want to be a little more cognizant. One of the things we haven't covered, I'll just put a little plug in here. When women have PCOS, other metabolic problems, they're at an increased risk for. One of the things we see is they have problems with cholesterol, what we would call a dyslipidemia. They tend to have higher triglycerides, higher low density lipoproteins, lower high density. So their cholesterol profile puts them at increased risk for heart disease. We see more sleep apnea and the problems that come out from sleep apnea. We, of course, see more diabetes as an outfall from PCOS. So women who have this diagnosis can have other metabolic long-term chronic issues that need to be evaluated and treated to help maintain long-term health, decrease
Gotcha.
cardiovascular.
Yeah, it's a big deal. Maybe while we're on this, let's ask the question, are there things that we need to worry about for the PCOS person who goes into menopause?
That's a good question. I've always been of the mind once the ovary slows down, the androgens slow down. PCOS is a condition of reproductive age and not postmenopausal age. But with the conditions, increased risk of dyslipidemia, increased risk of type 2 diabetes, increased risk of sleep apnea issues that come from that. Yeah, they're at increased risk for those. So they need to stay
Mm,
vigilant, monitoring for that. There's evidence that if you have these conditions, it increases risk of cardiovascular events. And we know that women, after they go through menopause, they're at increased risk for heart disease. So, yes, they should be staying up on surveying for that, treating issues as they come up, and doing what they can to help normalize those risk factors.
that's great. That's a great answer. Okay, we're going to just wrap it up for a couple of things, and I'm going to break it into this. I've wanted all of our experts to be able to just address this question, which is what is the message you would like to get out to the listener that would be for their greatest benefit? And maybe we'll just couch it into like 5 things that you would like people to know about PCOS to make sure that they are aware of and that they're looking for.
So, I would say one of the first things is if you have irregular periods, don't ignore it. Come get it evaluated because there are long-term consequences of having irregular cycles, whether they're the PCOS patient, long-term consequences include risks for cancer down the road. So get evaluated. Don't I see patients that come in and they haven't really had a chance to talk to anyone about it, or they don't want to bring it up with their primary care physician. But that's something that we need to get looked at and addressed and see what we can do to help. You don't have to live with crazy, irregular, unpredictable periods.
It's great.
And there are, if you're struggling with weight and you fit the picture in terms of the profile of the PCOS patient, it's not your fault. Sometimes it's completely out of your control. And this is where medication and treatment can help you eliminate the long-term risks of struggling with your weight or the things I just listed in terms of high cholesterol, heart disease risk, those kinds of things. Just, it's not your fault. Sometimes this is out of your control. I have to talk to patients that look, the body's kind of fighting you, and this is what we're working with. And we just got to figure out how to get your body back in balance. And if you need medications to help with that, then we do it. Sometimes people's eyes don't work and they wear glasses, and then it's fine. It's
Yeah.
not that simple. I'm not trying to simplify it but I think people feel like that they should have more control over this than their body allows them. And That's just part of our bodies being imperfect. They don't always function perfectly. For the third thing is that we haven't really talked about the infertility aspect of PCOS and how difficult it can be to get pregnant. And there are great treatments. We have great data, great information on things that work to help women conceive and grow their family if when they struggle with irregular periods due to PCOS. And I see so many couples come in and it's like they've been trying and trying and they're frustrated and you get the cycle history. You're like, oh, we could have helped you a long time ago. So don't be afraid. There are treatments, there are ways that we can work to help you from a fertility standpoint and things that we know that work because we understand what happens physiologically in PCOS and how to overcome those hurdles. So bring it up with your primary care provider, bring it up with your gynecologist.
Great.
And if, fertility doctors can help in that department, but they're not going to help with the long-term management. But we want to make sure that we're trying to keep women as healthy as possible that have this hormonal imbalance and trying to protect them from the long-term consequences of it going untreated.
That's great. Okay.
Don't be afraid.
3. That was 3. I'm going to have
Okay.
you give me one more. I know 5's a tough one.
5's tough.
I'm going to add one while you're thinking,
Okay.
which is don't think that your ultrasound diagnosis of a polycystic ovary or having cysts on your ovaries equates to PCOS, because we've talked about some really terrible things. And just because you have that ovary that shows some cysts, I think we clarified that there's no consistent advice on what the number of cysts are required to get your PCOS diagnosis. And so don't think that all of a sudden, because you have cysts, you have PCOS. I'm going to add that one.
Funny you bring that one up because I had a patient who was transitioning from breastfeeding to not breastfeeding. She had a really heinous long period. She went to the ER, they did an ultrasound and said, oh, you've got a polycystic ovary, you must have PCOS. And she never had that in her life. I said, and I pulled it up, I showed the images, it didn't have that classic appearance, did it have a couple of different cysts? Yeah. I said, I think this is all just hormonal transition and that your body just needs some time to get back on track with your regular periods. And it doesn't happen like a light switch. It takes some time. So I said, don't go down the Google rabbit hole about PCOS. You've never had a history consistent with it. You've never had any issues with it. And we're just at a snapshot in time that your body's trying to go from one mode to another.
Yeah, that's great.
Reflected in the ovary. Not every teenager that misses a period or two has PCOS. I think we need to realize labeling a teenager with that diagnosis, we've got to make sure that we've had time to see, is it really that, or is it what they're doing in life? Is it a stressor, or is it just part of their maturation? And we don't need to carry that diagnosis through the rest of their life. And that would be another thing is with the adolescent, the teenage population, you have to be super careful. In fact, they don't even want to give a diagnosis to a teenager of PCOS. Maybe at risk for PCOS, but that's why I say I wouldn't label a teenager with that until we've got a few years under our belt. We know exactly what that we've had time to get a good history.
I'm going to say one that's going to decrease the burden for you, which is because I can hear it in some of these questions, which is stick with your provider on this. PCOS is not one of those things that you walk in like to the dermatologist's office and you say, oh, you've got a mole and this is what it is. I think there's so many different presentations to it, and it sometimes requires time to get to that diagnosis.
Yeah, absolutely. And there isn't one laboratory value that will clinch the diagnosis. A lot of people want their hormones checked and labs checked. It is a syndrome. It is a clinical syndrome. Labs help us. Ultrasound helps us. Labs can help rule out other things, but I would never clinch the diagnosis with one lab value. or one ultrasound or
That's great.
1 month in time frame. We got to have time. We got to look at the picture. And I also want to, here's another plug, would be birth control pills in this situation can be one of our best allies. A lot of people get freaked out about being on pills. They don't like pills. I think for this particular hormonal condition and syndrome, the birth control pills have the potential to make women feel better because
great.
it helps regulate the hormones. Let's see. Was there anything else? I think that's it. And
That's great.
there was
Perfect.
just one more plug is that there's a higher correlation of depression and anxiety with women who have PCOS. So that can also be part of the picture too, but I wouldn't use it as a diagnostic tool, but I would be looking for it in someone that's struggling with their PCOS to make sure all their needs are addressed.
That's great. Jen, this has been so enlightening, so amazing.
Good.
Thank you.
Good.
I'm just going to say a few things before we finish that we must
didn't even
clarify.
get the ovarian drilling, did we?
We didn't. Do we want to say anything
No.
about ovarian drilling before we finish?
No, there's not good literature on it. Hardly anyone does it.
Yeah, I agree. All right. We must clarify that the medical advice or any procedural advice do not substitute for your own professional medical consultation. In addition, listeners or viewers need to be aware of the limitations of the information that we provided today generally. Thank you to all those who have made this possible. You can find this on Apple Podcasts, Spotify, Amazon Music, and on YouTube at Not Your Doc Anymore. You can also find us on Instagram and TikTok at Not Your Doc Pod or DocWatts_. And just a final plug for our president CEO of Not Your Doc Anymore, LLC, Natalie Watts, our social media managers, Taylor Seberg, Emily Brown, Sarah Marion, and our production manager, Joshua Watts.